My name is Samantha Booth. As Rachel said, I'm the local health and care lead for ONS, and my role is to understand how the health index and other ONS health data can add value at a local level. And I'm joined today by Greg Seeley, who leads the development and the delivery of the health index. So for us, it's great to be here. We're really keen to talk to you about the health index and to hear what you think about it and get your feedback, particularly about our next set of priorities, actually. That'd be really useful. So this is the plan for today's session. First, Greg will talk about the health index, what it is and where it comes from, including kind of the methodology that underpins it. And then I'll talk about, look at some of the results which were published on the 9th of November. Then we'll have a look at how you can access the health index at local level. And finally, we'll share what's next for the health index. And as I mentioned earlier, we'll pause a couple of times so that we can look at some of the polls and get your feedback. So what's the health index? Shall I hand over to you, Greg?
Thanks, Sam. And sorry, everyone, for my very dramatic lighting today. I've had to close the curtains behind me so you can actually see my face. I promise it's actually quite light in here. It just doesn't look that way on the camera. But yes, so what is the health index? The idea for the health index came from the 2018 Chief Medical Officer's report. That was when it was Dame Sally Davies before Chris Whitty, which said that there was a need to track health for the longer term and to measure health in its broadest sense. So that's including health outcomes, risk factors, and the determinants of health. The report also said that we needed to recognise health as one of our nation's primary assets, and the index should be considered alongside GDP because we have several economic measures of the nation's progress, but it would be great to be able to measure health alongside those to get a richer picture of what's happening with the nation. So our way of measuring health across that wide definition is to divide it into three domains. These are the ones on screen. Healthy people covers health outcomes such as physical and mental health conditions, well-being and mortality. Healthy lives are your individual risk factors and health-related behaviours. So we have in here things like the life chances of children and young people, alcohol misuse, smoking prevalence, cancer screening attendance. And then healthy places is your wider social, economic, environmental drivers of health. This is stuff like unemployment, child poverty, air pollution, and crime levels. We've developed this with research and the use of an expert advisory group, because of course, when you're measuring a topic as broad as health, lots of people will agree and disagree about what should and shouldn't be in scope. So in order to develop the health index, we worked with an expert advisory group of about 30 organisations. This was a mix of central government, local government, the voluntary sector, think tanks, academics, to really make sure that the index would be accepted by as many different types of health analysts as possible. So we've developed the health index as a tool to help people understand the health of their local populations. It gives a figure for England, but also for regions, ICSs and local authorities. And our overall aim is to add value to the existing evidence base, because there is a lot of health and care data out there already, but we want the health index to be used alongside other data sets such as these and other tools. So things like Public Health England, now OHID's fingertips tool, ONS's own subnational indicators explorer, and the index of multiple deprivation for you to really understand what's going on with health and what's driving it. Overall, our method for producing the health index is consistent with COIN, which is the Competence Centre on Composite Indicators and Scoreboards. I'm really glad that's on the slide because that does not spell out COIN at all, and I always forget it. But this is an OECD-led methodology for 10 steps to construct composite indicators in a robust way. Those 10 steps are on the slide here, but I'm going to cover them as 4 different categories, which are also shown here, of how we reviewed the data landscape, decided what was and wasn't suitable for our inclusion, and then the nice technical part on how we actually group these to turn them into a final index score, which I'll say a bit about here, but very happy to take more questions if you want an even more technical explanation of what's gone on in the background to create the index. So on the data landscape, in order to work out what was and wasn't available for the health index in the first place, we conducted an extremely comprehensive review of existing frameworks such as NHS's Quality and Outcomes Framework, the Adult Social Care Outcomes Framework, and composite indicators where they were available. So this includes stuff like the Index of Multiple Deprivation, but also wider health-related data. So there would be things which weren't in existing outcomes frameworks or weren't in existing indices because they were newer as stats, or they may not have been suitable for those other frameworks, but were suitable for what we were looking for. The idea is we wanted to see that when other stats have measured health, how have they gone about this? What have they seen as in scope, and which data have they seen as suitable? And we were helped by the fact that ONS has the health and social care data landscape tool, which allows you to put in a search term and review all of the official stats data sources available that are relevant to that term. So using these pieces of information, we produced a concept of how the health index could be structured and what could be in scope for our 3 different domains, and ran this past our expert group to make sure they agreed on what we had considered in scope, they agreed on what we had considered out of scope, and then used that to inform our first version of the index. Of course, there would be some data which other sources had deemed suitable for inclusion and didn't quite work for our purposes. Because we were measuring health specifically, every source we use needs to have a direction of change that represents a change in health. So we need to be able to say, if this goes up or down, does that mean that health is changing over time? Is health improving if it goes up or down? Is health declining if it does the opposite? Because that's the nature of what the health index is trying to measure. This means that some measures aren't quite as suitable as others, especially if we have if we consider how we measure cancer, for example. If people are living longer with cancer and having better lives with cancer, but we're not able to cure cancer more, then we will see more people living with cancer, but that wouldn't necessarily mean that we have worse health. So just measuring the number of people in the population with cancer wouldn't necessarily be a fair way of saying health is improving or declining. And it's these sorts of discussions we had at all levels of the index to make sure that what we were producing was watertight. Similarly, we needed these to be disaggregated to lower tier local authority level at minimum, which is an improvement on the initial upper tier local authority, but I know there's still a way to go, and we'll talk about that a bit later on. But similarly to there having to be a direction of change that represents a change in health, we really wanted to measure health rather than health services. We want the index to be capable of assessing the impacts of policy, and that will mean that we'll want to be able to map health services to it in some way, but we wouldn't want to make it so a change in health service in the absence of a change in health would lead to a change in the health index. An example of this would be adult social care. Right now, some people are eligible for local authority funded social care, and if we measured that within the index and then government changed the eligibility criteria, we would see more or fewer people eligible for that without an actual change in people's health. So we wouldn't want to measure that if it didn't measure people's health. Now onto the really fun bit. To turn the health index into the structure as it's published. Yes, we had this conceptual idea of the structure from reviewing the data landscape, but we also used the statistical technique factor analysis in order to group our indicators together. What factor analysis does is it looks at which indicators explain like variance in the underlying data set and therefore appear to be correlated or grouped in some way. And you can see this from the correlation matrix to the right. This is the type of thing that we squinted at a lot when working out what would be meaningful groups for things. The idea of factor analysis is that each of the factors became one of our index's subdomains, and I'll show the overall index structure in just a moment. But factor analysis is in itself both an objective and subjective tool. It does provide statistical significance to say what is and isn't a meaningful group to put together. But we also knew that in order to maximize the index's accessibility to users, the groups we put together had to be thematically meaningful. If there wasn't an obvious reason why mortality and diabetes were in a group on their own together, for example, then it wouldn't be very helpful to users to interpret what different groups meant. So we weren't beholden to factor analysis, but we stuck to it as far as possible when seeing if the structure that it came up with for how indicators could be combined didn't match what we had expected, we would test what we had expected and see whether it was happy to create a one-factor solution, i.e. put those things together. And if it was, then that's something that we would test in the index and see how that looked. And if it wasn't, then we knew that how we'd decided to group things wouldn't be robust and we'd have to come up with something else. So there was a lot of trial and error, and every time there are new indicators added, there's a lot of the same to get this through. I mentioned that, sorry, one last thing on that slide, Sam, sorry. I mentioned that we looked at the amount of underlying variance in the data that each indicator explains. Each indicator has a weighting on its factor of how much of that factor's variance it explains, and that's what informs the weightings of indicators within their subdomains. So if avoidable mortality explains 80% of the variance in its subdomain, then it would have 0.8 weight within there and that sort of thing. And then on to the last bit of the methodology, how we actually turn these into index values. Everything is time indexed standardized. This means that a score of 100 for any indicator, any subdomain, and the top level index means that your health is equal to England's health in 2015. This was our base year because it was the year for which the vast majority of our data were available, rather than it being a particular milestone for England's health. But across all of the index, having a higher score than 100 means that your health is better than England was in that year. Having a lower score means your health is worse. And in any given year, having a higher score means your health has improved, and having a lower score means your health has declined. At local authority level, this is linked to standard deviations. So if you are 10 points higher or lower than another score, then you are one standard deviation better or worse health in that topic than the number you're comparing to. But having this method for putting the index together means that, unlike many of the other indices and outcomes frameworks we were looking at, we've succeeded in having a single number for health which you can track over time meaningfully. So your scores in any year are referencing this 2015 base point, but are comparable with your scores in any other year for any topic, for any geography. So what does this actually look like? The end result is a health index where we've got this top level index score. Each column here is one of our 3 domains, and the boxes within them are our subdomains. So we end up with 14 subdomains across our 3 domains, each with a thematically meaningful and statistically robust combination of indicators within them. And overall, these subdomains are populated by 56 indicators across the whole index. One example of this is shown in the middle, where for protective measures under healthy lives, there are 2 indicators informing that, one being attendance of booked cancer screenings and child vaccination coverage. So this is where we get to following all of this methodology to bring stuff together and decide which data are suitable and not. And this allows us to produce index scores for all of these different components at indicator, subdomain, domain, and top level index score for comparison over time, and allow people to see if health is changing on the whole, what's driving that. You can drill down into these different topics, and that hopefully allows people to target their interventions if they can see where their health is improving or declining and what appears to be driving that. I think that's enough from me for now. Very happy to take more questions on the methods later on, but I'll hand back to Sam to tell you a bit about our latest results.
Great, thanks, Greg. So yeah, moving on to the results then. So in general, at a national level, we don't expect the health index to show much change year on year, as improvements can take time to become apparent. But when we looked at the health index for England from 2015 to 2019, our health as a nation was not showing a consistent year-on-year improvement that we would like. The health index for the East Midlands remained stable, and the West Midlands decreased slightly by 0.9 between 2018 and 2019. So I think it's useful to consider some of the underlying health challenges we faced ahead of 2020. So healthy people saw mental health and disability decline from 2017, and personal well-being declined in 2019. Healthy lives saw a worsening of drug misuse, healthy eating and obesity, both for adults and children. and healthy places saw low index scores for access to services, personal crime, and although unemployment and job-related training improved, that was kind of a, well, as you'll see as we go into that's a position pre-2020. So at a high level, this means that the underlying picture for health as we went to 2020, which of course is a year that the pandemic started. And this is the picture for West Midlands and East Midlands. So when we look at the health index in 2020, healthy people declined considerably for England, driven by higher mortality, worse mental health, and considerably worse personal well-being. And the same issues were seen in the Midlands. Healthy lives declined for England and generally showed a mixed picture, and there was a similar pattern for the Midlands as well. And there was an important improvement in healthy places, due in part to factors such as better air quality, rough sleeping, and less crime. And this is likely driven by the need for people to stay at home during this time. And this combination of changes led to the overall health index declining slightly for England, but also declining slightly for the West Midlands, but remained stable for the East Midlands. So moving on to look at further at patterns of health across the Midlands. So I'm not sure whether Greg mentioned it, but we now publish data at ICS level. So we've got data at England, region, ICS, upper tier and local authority level. So, but as you might expect, we see a greater variation when we look at the lower levels of geography. And as Greg said, lower tier local authority level sees the difference of 10 equating to 1 standard deviation. So when we start to look at the left-hand side, we can see the nice picture for the ICS. But when we start to look at the middle, we can see that Leicester and then Oadby and Wigston, who are neighbours in the Leicester and Leicestershire and Rutland ICS, see quite a difference in the overall makeup. So to move from the overall ICS level to the individual local areas, you can see great difference. And that difference between those two areas is over 20 for healthy people. And what this means in practice is that the population of Leicester had higher levels of frailty and mental health conditions and worse values for children's social and emotional mental health, as well as mortality rates. And these differences really illustrate the importance of looking at the data at a local level. So I'd now like to look at the health index says about the health across geographies and over time. So just to orientate ourselves, a low value represented by the lighter green depicts a worse value on the health index. And as we move into the blues, the values improve, and the darker the blue, the better the health index value is. So this slide shows the overall health index score for local authorities in the Midlands from 2016, 2018 and 2020. And as you can see, the patterns of health and ill health persist over time. So I've kept the scale the same as the previous slide and now turned to look at the domains of healthy people, healthy lives and healthy places. First in 2019 and then in 2020. So here's 2019 and this is 2020. Between the two. So if you move between the two, you can see that healthy people declined across the Midlands and healthy places improved. For healthy people, around a third of the local areas had scores that were less than 90. Chesterfield had the lowest score at 77.7, and only 3, Oadby and Wigston, Rutland and Derbyshire, had scores above 110. For Healthy Lives, 10 out of the 65 had a score below 90, whilst 21 had a score above 110, with the highest being Rushcliffe at 130 and the lowest being Sandwell at 81. When we look at healthy places, only 2 scores were below 90. These are Nottingham and Birmingham, although close to half had scores above 110. For Nottingham and Birmingham, they both had high levels of crime, child poverty and unemployment, and that's what's driving their lower scores, amongst other things. So here we start to see that the variation across the Midlands and that each area has its own challenges to address. So one way you can explore the health index scores across England is to use this tool on our website. So I'm going to click on a recording. If you could just put a thumbs up if you can hear this to make sure that everybody can. So as you can see by looking at these two maps, there's a correlation between deprivation and the health index. As the health index describes health in its broadest sense, it does rightly include some measures of deprivation, such as unemployment and child poverty. And this reflects the importance of these wider drivers on the health of individuals and communities. Deprivation is a factor in health, and similarly, health can be a factor in deprivation. For example, the economic activity rate of people with long-term conditions is a fifth lower than for those without a long-term condition. So one of the reasons we see a correlation between the health index and the index of multiple deprivation is because there is an overlap in some of the measures that are used. But as we'll see on the next slide, the relationship between the health index and deprivation is not solely down to the inclusion of the same indicators. So this chart shows the health index values for behavioural risk factors, which covers alcohol and drug misuse, healthy eating, physical activity, sedentary behaviour, STIs and smoking. The measures covered by behavioural risk factors are not in the IMD, but in 2020 there was a 27-point difference between the least and most deprived areas. And the gap between the least and most deprived has been increasing in recent years, driven by a decline in the index values for those the most deprived areas. So it's 3 times more expensive to get the energy that we need from healthy foods than unhealthy foods, and working long hours or multiple jobs can leave little time for planning and preparing meals. And we also know that deprivation places additional stress on individuals, and that behaviours such as smoking and drinking can be coping mechanisms. And this means that it can be very hard to change these behaviours without changing the stresses themselves. So that's the result. So moving on now to looking at the health index and how you can use it at a local level. So Jim McManus, president of the Association of Directors of Public Health, reflected on the use of the health index in this quote. Jim talks about the index providing a unique overview, the health index, that it can be used to compare and track the impact of policies and programmes and support decisions in relation to health initiatives, with that ultimate aim that we all have of allowing people to live longer and healthier lives. And whilst I've largely talked about a health index for the Midlands and the variation across the Midlands, I could have been talking about an individual ICS, a combined authority or local authority. The health index can be used as one of the tools that you can use to explore the story of health in your area. So how do you access the health index data and information? We've made the index scores for all local authorities and ICSs and the underlying data available in Excel spreadsheets on our website, and the links are available here. This is supported by documentation on methods, indicator definitions. We also have this tool which helps you to explore the health index at a local level. So I just wanted to share some of the feedback we've already heard. So what we've already heard is that the strength of the health index is in its simplicity, that it can quickly and easily provide a good overview of health in an area, that reviewing the health index reinforced existing knowledge about health, but also identified some new issues to explore, that the health index can provide an element of independence, which when coupled with local measures can support a robust assurance framework, and that a discussion centred on the health index has led to the wider determinants of health being recognised. And just more generally, it's just a useful addition to the local evidence base. But we've also heard that people would like more detailed geographical health index and for it to be more timely. So we'll return to that later. So now it's over to you, and the poll. So I don't know if it's over to you now, Rachel, to put that back into Menti. But we're really interested in knowing how likely you are to use a health index and what sorts of things you might use it for. If health index is new to you, you might not know yet, so you're not sure is absolutely fine. But if you can select all that are relevant from whether you want it for an overall view of their area right through to whether you want to see it encourage that longer term view of health improvement.
Okay, so I've got the questions separately. So if people are engaging with the first one now, oh, it's disappeared. So if I just share my screen so you can see how I'll do the big reveal, shall I? So this is what people are saying about the first question. So there's a few don't know, so there will be people who aren't familiar with it who are here to learn all about it, which is great. There's a lot of quite likelies, which is probably what you are quite interested in, and very likely. So I imagine those are people who are maybe already familiar with it or familiar with sort of existing or similar approaches, or they can simply see how it would work in the work that they do. Shall I move on to the next question? Are you happy with that?
I'm very happy with that, thank you.
Okay, I'll move on to the next one, which is kind of in two. I couldn't work out how to do choose between these and then make a statement as to where else you'd use it. So it's on a separate slide. If indeed people do have an other category which doesn't appear here. So there's a few words on this one, so it'll take a few people. It'll take people to read them before making their selection. I'll just let people absorb that info. So are these the results you're seeing? This is kind of what you would expect, or is this what you'd want? Is there anything here that you would prefer to see more of, Sam?
Obviously, how people want to use it, I'm completely happy with how that would be. I suppose often we see a greater focus on the ones that have got 0 here. So and that might be down to how I've kind of described it, but one of the reasons for the health index is to try and make sure people keep a longer term view on health, rather than that kind of immediate, actually what can we achieve in this next year. Some of these things take time, and therefore that kind of longer term view. And I think probably for some audiences, and perhaps not this one, there is a real drive and a need for people to really want to keep that focus on healthy lives and healthy places, so the socio-economic determinants of health, because there is always so much focus on health services and health outcomes, and it's those other things that actually draw out those longer term improvements and prevention. But absolutely, however what people want to use it, that's great.
Okay, that's great. I'm just going to move on to the next slide, just in case So there's one person who said, what else would you use it for? So that's what this page is for. So if there's something in all of your categories that people they would use it for something different, this is an opportunity for them to do that. And if that's too difficult to think about at the moment, I can move on to the other question that you have. Shall I move on to the last question?
Could we leave the last question for now?
Yeah,
it's
yeah,
about
absolutely.
how you inform. It's really useful. So support the inequalities work is a key one for me as well.
Absolutely.
Yeah, because I want to tell you about what our opportunities
Sure.
are for development, then get your view on those.
Sure. Well, I'm just allowing people to think. I'm terrible at allowing people to think. It's instant or nothing. Like I don't think like that. So
Yeah.
that makes perfect sense, doesn't it? So population health management, it's a perfect tool to support that and all inequalities work. And someone's said most of the previous options, yeah, you're not going to do one thing, and it's probably going to be a bit of everything, isn't it? If you're using this tool. It shows where to involve community more. That's a very good point. Yeah, and there's a comment here about wanting to understand it better, to see how it can be used. Service, health and social transformation. Obviously, it measures health, but in order to look at the impact of services on health, you look at both, don't you? Inequalities and PHM. Okay, that's I'll move us on now. So in other words, I'll stop sharing and I'll allow you to talk, Sam.
It's really helpful, thank you. I'll reshare my screen.
Okay.
Let's see if I can resume where it was. Okay, so can you now see a slide that said what's next?
Yes.
Perfect. So we know that there's more we can do to increase the value of the health index, and our first ambition is to improve the timeliness. While many aspects of health take time to improve, we know that timeliness of data is important. So we're publishing the next set of results in spring 2023. And our ability to improve timeliness of the health index overall is limited by the availability of underlying data. So we're also exploring options such as making the index values for individual indicators available in between publications so that the latest position for each indicator can be tracked. So feedback's also suggested that to explore an issue, you'll often want to use the health index alongside a wider set of evidence. As we've said before, the health index being one tool in a toolbox, with the impact often coming from the combination of those tools. So we've heard that the ONS can add value by connecting the health index to related national insights, relevant associated data and neighbourhood information. This has led to the idea that we could bookend the health index, adding value at one end by signposting national insights, particularly those from ONS, and at the other end by considering more granular data sets such as census, the index of multiple deprivation, and importantly local data, including user feedback. So recognising the value of exploring the health index alongside wider and more granular data, we plan to make it available through other dashboards such as fingertips. We also plan to improve the search terms in the healthcare statistics, which is a tool that signposts the statistical publications irrespective of which government department produced them. This will make it easier to connect from a health index topic to other relevant statistics. We're also exploring causal inference with the Alan Turing Institute and looking at how existing evidence of research can improve our understanding of causal relationships within the health index. Our current plan is to review causal information on a topic-by-topic basis, taking one or two topics to understand what value exists, what already exists, the value of the work and its feasibility. Greg, do you want to take this one, or do you want me to do it?
I'm all good. So alongside development of the health index, we're also building a simple, flexible health projections tool, which aims to show both the trajectory of an aspect of health in the absence of any intervention and what the impact of any interventions would be, which the user can select. We've developed this with an expert advisory group, similar to how we developed the health index, in this case including epidemiology modelers at Newcastle University, OHID's modelling team, ONS's population projections team, and data ethics experts. Our aim is for the model to show how changing one aspect of health will impact others, how that would also have impacts on different parts of the nation in different ways, and how changes could affect health overall. So, for example, if you were to change obesity rates, what might that mean for various conditions? And how much difference would you see if you're aiming for a national target change, what that might mean for different local authorities based on their current rates? The image that's on the slide is the model in its current form, and hopefully you'll think it's looking quite polished, because we do. We're aiming to have this version shared on GitHub before the end of the calendar year, so we can begin user testing with our expert stakeholders and further develop it, using their feedback. We're also exploring with ONS's digital publishing team how we can host the tool publicly to maximise the use it can have.
When we published the health index, Chris Whitty provided this quote, which talks about the value of gathering information on health challenges and the stark variation that exists across the country, and the value of more granular data. So our collaboration with Northumbria Healthcare NHS Foundation Trust has shown the potential for the health index to become a small area health tool. Working with ONS, the team at Northumbria have used the health index framework to create their own beta version of a local health index. Applying the methodology at a lower super output area, each one covering approximately 1,500 people, Northumbria have been able to create a local health index for each of their 328 SOAs. The analysis has created a deeper understanding of how health and the drivers of health differ between local areas within Northumberland and North Tyneside, providing a data-driven framework to tackle inequalities in health. With data drilling down to neighbourhood level, improvements can be planned for areas and communities where they are needed most, with the aim of increasing impact and value for money. So ONS are continuing our work with Northumbria to explore the feasibility of a local health index for other local areas. So I suppose that's give you a sense of the developments that we're kind of exploring. And I suppose what we wanted to know from you is which do you think are the most important things? And I've got to put a disclaimer on this because it's highly likely that we won't be able to achieve all of these things, and everything's going to be subject to resources and feasibility. But if Rachel, if you can share the last Menti slide, it would be really great to get people's views and input into the priorities.
Okay, I've moved it on now to those questions, and we've got it as a rank, so I think people can choose more than one. Hopefully people can see that on their screens now. Because I'm doing it again, I'm giving them like 0 seconds to read anything. Come on, you guys. So I'll share my screen so you can just realize it's fun what I'm looking at, but no one else is looking at it. So I will. There we go. So now you can see what a beautiful pink color we have in first place. Okay, I'm not surprised by that. Thank you. And a cup of tea has arrived. I'm not surprised by people wanting more detailed geographical data. I think that was one of your the feedback that you've had so far, wasn't it, Sam, as well?
It's interesting to see more timely and causation flip between the two, because I think what we've generally your first priority is definitely consistent with what we've heard from everywhere else. I think elsewhere more timely data is also seen as important, as you've got here, and then causation and projections are kind of the next kind of priority. So yeah, a lot of similarity, but the more we can build this picture of what's important, the more we can make sure we're driving our improvements driven by user feedback. That's really helpful to see.
Yeah, I mean, that's really important, isn't it? I can see, well, everybody on the call, many people on the call work for a local system, and they will want that picture at that level so that they can sort of target and have a better understanding of their own populations. So that would definitely be sort of a priority. Personally, I should think timely data is important, but it's a lot of this data isn't necessarily sort of frequently produced. I suspect behind this. Okay, well, I think that's great. If you're okay with this slide, my next slide I think is just a general. If people have got any comments for you, but I'll stop sharing and come back to you too. There's a comment in the chat that might be.
Oh, I've not seen that.
All right, so Jane is saying she would like to have been able to select more than one. Of course, that's my bad. I was supposed to set it up so that you can select more than one. So I take full responsibility. Sorry, Jane. You can contact us separately and find out what the other things that you'd like to have selected. But yes, I can get that as well. You want to select more than one. That's how Sam asked me to set it up. Just read the email, Rachel.
We haven't really got any more slides, but it's, our final slide is just what are your reflections, comments and questions, and we do actually have a survey which we can send around. So if you did want to kind of give us the ranking as opposed to kind of your top priority, you can do that via the survey. That would be
that'd be really helpful.
I hope you found that useful. Yeah, any questions?
No, that's great. So thank you very much, both. That's really interesting, but it's also looks to be a really valuable tool going forward. I did wonder how, you probably said in the presentation, but how long, I feel like this has been on the cards for a while. I just wondered how long it had taken to get to this stage. How long was the development and the
I didn't actually say that. It had been explored a bit between ONS Cabinet Office and DHSC in 2019. The team was first set up to develop it in 2020 at the very start. Then, of course, for obvious reasons, priorities shifted about during 2020, but it was the end of that calendar year that we got out our proof of concept, which only went up to 2018 and was at upper tier local authority level. We ran a public consultation alongside that for 3 months to see what people thought and how we could improve it, and then spent the best part of 2021 dealing with the very positive challenge of having lots of user feedback to address. So getting that first version out of the proof of concept took about a year for the team, with obviously COVID getting in the way and doing lots of stuff to our priorities and our to-do lists. 2021, of course, there were still impacts of COVID, but we spent the majority of that year addressing our consultation feedback, doing some engagement with organizations to see what we could do, and then got our first post-consultation full version of the index out in March this year. So it has taken time to get it right. It would probably take even longer if we didn't have such an excellent team around us doing all of that hard work. And there are still things that we want to improve and address. There are definitely parts of the consultation feedback we haven't been able to prioritize yet. So it will still change shape based on conversations like the one we've had today on what you'd like us to look at next and what you'd like us to prioritize. So yeah, this stuff has taken time. But hopefully it's given us a good proof of concept in the same way that the Northumbria work Sam showed has as well. That means that any further developments will be faster and faster as we've got more and more experience in this space.
No, that's good. I mean, the thing is, you can't actually rush this type of process anyway. Yes, there were interruptions, but it's something that you need to do properly, isn't it? It's something that you've gone through those different stages to make it a robust health index. I'm just looking at the comments. I know that many people can't actually access the chat box. I don't know whether you guys can see it, Sam and Greg. So if it feels so, I will read out one or two of the comments. We've just got time for a couple of comments. So Sam Jones is saying, is the index or underlying indicators age standardized in any way? For example, if the healthy people one is based on indicators such as cancer, dementia, and so on. So are they standardized? Does that work with factor analysis, or is that different?
They aren't currently, and factor analysis is the reason. We have age standardized measures for a few of these indicators. We found that if we had some age standardized and some not, then they didn't combine in the factor analysis in a way that we thought was meaningful. So we do think that age standardized measures are an improvement, and it's something we're looking at moving towards and seeing, even in the cases where the published data we're relying on aren't age standardized, if there's anything we can do to age standardize them ourselves, is one of our development areas we're keen to explore. In the meantime, some of our tools in the past have allowed for us to plot the scores for local authorities against each other for different aspects of the index, and that includes being able to present those data based on the age distribution of the population. And that can give you a sense of, if you are seeing differences between areas, is it driven by age? But that's not something which our latest tools are able to show. So there is a lot more for us to do on age standardization, but rest assured, it is on our to-do list.
Okay, so you still got a job.
Definitely.
There's just a couple more points. I don't think we're going to have time to answer them, so I'm going to have to share them with you after, and then maybe we can share your responses back to the network. So Richard Cooksey asks, would you advise looking at individual data before making conclusions, etc.? As for our borough, big changes in scores are likely to have been impacted by changing activity in the pandemic. So I think it's just some sort of advice on how to look at the data. So would you advise looking at individual data before making conclusions? Then Steve Wyatt from the strategy unit. I read out his comment because it's a very positive comment. He says it's a really impressive piece of work. Having a consistent index over time will be particularly helpful. You can quote him if you want. I'll allow you to do that. And he has a couple of questions as well. So the first one is, does ONS publish confidence intervals around the health index scores? And I'm going to go straight into the next one because I suspect we won't have time for you to answer these. His second question is Steve's second question. Does ONS believe the health index is estimating a real quantity? If so, how confident is it that, or are you that it is that changes or inter-area differences in the index reflect genuine changes and differences rather than artifacts of measurement of the measurement method? So it's an index, isn't it? So and then you kind of want to translate it into real things. So do you understand the question? I will share with them later. And did you want to respond to any of those before we run away? I think I'm going to say no, because I was
going to say it depends whether you want to get away at 12 or not.
Yeah, I'm a hard finisher. This stops now. I'm going to share them with you. I'll share those, and I probably read them terribly. And
we'll definitely commit to coming back to you on those answers. And they're really good questions, questions.
Yeah. So thank you. I haven't had time to go through one or two other things, but that's very normal for me. I'm terrible at time management. It's been lovely to meet you both. Lovely to see you here today, and thank you very much for sharing the health index. I look forward to updates. You're welcome back anytime to share more updates on the health index. So thank you everybody for coming, and I'll see you this afternoon at the final Insight event, which is 2 o'clock. That's Sir David Walton. I've made his name up, Sir David Dalton, and he's going to be talking about the craft and science of landing those decisions. So come to that event. It's our final event. Great. I'll see you again soon, everybody. Okay, bye-bye.